Welcome to the Explainer. Today, we're jumping into a tool that is absolutely fundamental for any healthcare professional in an emergency, the abcde assessment.
Think of it like a life-saving game plan. It's a systematic approach that helps you cut through the chaos to find and fix the most life-threatening problems first.
The core principle here is simple, but it's non-negotiable. You have to follow a strict order. I mean, think about it, right? It's completely useless to address a breathing problem if the patient's airway isn't even clear. So let's dive into what that order actually looks like.
We're going to walk through each letter of this mnemonic, all the way from A to E. For each one, we'll cover what to look for, what it means, and most importantly, what you need to do about it.
Okay, first up, and this is without a doubt the most critical step. A is for airway. The first question you have to answer is their airway open, and can they keep it that way?
So, what exactly are you looking and listening for?
You've really got to use your eyes and your ears here. Visually, you might see their chest and stomach moving in opposite directions, or maybe that telltale bluish tint to the skin, which we call cyanosis. If you're listening, sounds like stridor, that high-pitched noise when they breathe in, or wheezing are big clues to a partial blockage. But you know what? The most dangerous sound of all is silence. That means a complete obstruction. On the flip side, if a patient is talking to you, that's a fantastic sign their airway is clear.
Look, if that airway is blocked by the tongue, a foreign object, fluids, you name it, you have to act fast. We're talking seconds matter, because a lack of oxygen can cause brain damage or worse. So the number one rule is to get help immediately, and then start these interventions, from basic maneuvers all the way up to advanced airway devices if you need them.
All right, so once you've secured that airway and you know it's clear, then we can move on to B, breathing. This is where we figure out how well they're actually moving air.
So you're looking at a few things: the rate, the effort, and the effectiveness of their breathing. You'll want to check their oxygen saturation, and you're aiming for that 94 to 98% range. Now, here is a really critical point to remember. You've got to be super careful with giving oxygen to patients with COPD. Too much can actually suppress their natural drive to breathe, which is a really dangerous situation to create. And speaking of rate, if you see a respiratory rate over 25 breaths a minute, that is a huge red flag. It's a key sign that your patient might be about to deteriorate, and fast. It tells you they're working way too hard to breathe, and they simply can't keep that up for long. And that distress could be caused by some really serious stuff: severe asthma, fluid in the lungs, or tension pneumothorax. Figuring out the right cause is vital, because each one needs a very specific and urgent treatment. For instance, a tension pneumothorax needs immediate needle decompression. Just giving oxygen isn't going to fix the underlying problem.
Once breathing is managed, we move to C for circulation. Now we're asking, is blood actually getting around the body and perfusing the organs?
Okay, there are two findings that when you see them together should set off alarm bells: low blood pressure, or hypotension, and a fast heart rate, called tachycardia. That combination is a major warning sign that your patient might be heading towards shock. And another quick check: a slow capillary refill time, if it takes longer than 2 seconds for the color to return, confirms that perfusion is poor.
The main reason for circulation failure is shock, and it comes in several different flavors. It could be hypovolemic shock from blood loss or distributive shock from something like sepsis. Now, this brings us to a really important clinical tip.
This is so crucial. In any patient who's had surgery, you always have to be thinking about bleeding as a potential cause of hypovolemic shock. It is a differential diagnosis you simply cannot afford to miss.
So, what do? You get IV access right away with large cannulas, so you can give fluids or even blood products quickly. At the same time, you're drawing blood for tests, including a cross-match, just in case a transfusion is needed. And then you start giving IV fluids.
All right, let's move on to D for disability. This is where we assess the patient's neurological function, and we usually start with their level of consciousness.
The AVPU scale is your go-to for a quick initial assessment. It's a super simple way to find out if the patient is A, for awake, V, for responding to voice, P, for responding only to pain, or U, for completely unresponsive. It's a great starting point before you move to a more detailed scale. Now, what's really important here is to always check their pupil reactions and, critically, check their blood glucose level. Low blood sugar, or hypoglycemia, is an incredibly common and easily reversible cause of altered consciousness. A simple dose of glucose can literally make all the difference.
And finally, we get to E for exposure. This means carefully examining the patient from head to toe to make sure we haven't missed any other clues.
You're looking for anything you might have missed, things like skin rashes that could point to sepsis, signs of blood clots, or any hidden injuries or bruises. And through this entire process, it is absolutely vital that you maintain the patient's dignity. So what is the single most important thing to take away from all of this? It's that the abcde assessment isn't a one-time checklist. It is a continuous loop. If at any point your patient's condition changes for the worse, you have to go back to the beginning. So the answer to that question on your screen, it's always A. You always start again at airway.